You're listening to the Blood Bank Guy Essentials Podcast, episode 24.
You know, I've collected some quotations over the years. One guy who told me that he'd rather go through chemo again than have the reaction that he had. You know, I've seen one patient run around the room screaming because she was in so much agony. And that was just hives. But, you know, so we don't get the whole story, and they really are a problem. They really are problematic.
Hi, everyone. Welcome to the Blood Bank Guy Essentials Podcast. My guest today is Dr. Will Savage from Harvard University. Will is here to talk about allergic transfusion reactions, which I think is a very underappreciated and somewhat under-respected topic, if you really must know the truth. Will and a group of amazing doctors at Johns Hopkins, where he was prior to going to Harvard, have their hands all over tons of great work in the last few years that's been published on allergic transfusion reactions, and there's a really broad spectrum of things that quite frankly has changed the way I look at these reactions, and I think it'll change things for you too. I'll have more to say at the end, so stick around after this interview for a couple of announcements. But now, I won't make you wait anymore. Here is my interview with Dr. Will Savage. I am really, really happy to welcome today to the Blood Bank Guy Essentials Podcast, Dr. Will Savage from Harvard. Will, welcome to the podcast.
Hello. Thanks for having me.
It's great for you to be here, my friend. I can't tell you how much I have kind of watched from afar as you published more and more stuff on the topic that we're going to discuss today, allergic transfusion reactions. But before we get to that, I would like to tell everyone just a little bit about you so everyone is familiar with you. Dr. Will Savage is an assistant professor of pathology at Harvard, and he serves as medical director of the Therapeutic Apheresis and Donor Services at Brigham and Women's Hospital in Boston, Massachusetts. He got his biochemistry degree from Columbia University, his MD from Weill Medical College at Cornell, and his PhD from Johns Hopkins in Baltimore. He has an interesting background. His background is in pediatrics, and he trained in both pediatrics and pediatric hematology oncology at Johns Hopkins, followed immediately, I believe, by a transfusion medicine fellowship at Johns Hopkins. And we'll talk about that in just a second, Will.
Sure.
In the time since Will finished his blood banking transfusion medicine fellowship, which is really not that long ago, he has published numerous papers, served on multiple national and international committees and subcommittees, and he's been recognized with numerous research and other awards, including teaching awards. So Will, you've been a busy guy, dude. I mean, a lot going on.
Well, we need to point out that you've been a busy guy too, Joe. And you have a great operation. I love your website and all of its content.
I appreciate that very much. I am curious a little bit though about your story, and I wonder if you wouldn't mind sharing with us just a little bit about what was it when you were at Johns Hopkins, or maybe before that you were at Johns Hopkins, that kind of set you down the pathway of turning your career towards transfusion medicine.
Well, I had always been interested in hematology, and during my hem-onc fellowship, I found myself curious about transfusion in addition to a lot of other things in hematology. And when I turned to the hematologists on questions of transfusion, there was often answers like I don't know, or other people deal with that. And I thought, well, geez, that's curious. What's going on in transfusion? And then I started learning more about what happens there, and right. I really saw it as transfusion as being on the spectrum of benign hematology. So it was really both curiosity and opportunity-driven decision.
Nice. Well, and you certainly had a fairly spectacular group of people to work with as mentors there at Hopkins, I would say.
Absolutely.
Yeah, they're okay. People like Paul Ness and Karen King and Aaron, they're all right. Sarcasm intended. I mean, obviously an amazing group of transfusion medicine physicians, and I'm sure I'm missing people as well. So tell me a little bit more though about your specific interest. You've focused your research on our topic today, which is allergic transfusion reactions. But again, before we get into the details, what got you interested specifically in that?
Well, like a lot of people, having the right mentor steers your career in specific directions. And as I was transitioning from research in hematology focusing on sickle cell disease into research in transfusion medicine, it was Paul Ness who kind of grabbed me by the shoulders and said, Will, nobody is working in this. These are incredibly frustrating, and there's so much to be learned, and it's wide
Yeah.
open for you if you want it. And he had assembled a small group of people who are interested in it. So I started
Uh-huh.
learning about it, and that's how it started.
I
It's
see.
kind of
I
like the
see.
graduate plastics, the
There you go. That's the future.
yeah, that's the future.
Okay, well, today we're going to take just a little bit of a tour through allergic transfusion reactions, and really what I am planning on doing is learning from you and hoping that our audience will do so as well. We've kind of got four areas to cover, and I think these fall pretty naturally into the discussion. First, we'll do the definition of allergic transfusion reactions, and then we'll talk about the epidemiology of allergic transfusion reactions, or who gets them and in what circumstances. The pathophysiology is third, and then finally the management and maybe prevention of allergic transfusion reactions. So before we do that, though, I guarantee you that there's some smart aleck listening to this podcast somewhere right now who is saying, allergic transfusion reactions, seriously? Do these things even matter? I mean, come on. So somebody gets a little rash. What's the big deal? So that's my first question to you. As someone with a history as a clinician, as you have, as well as someone on the transfusion side, what's the big deal?
Well, I think people tend to get desensitized to stuff when they to that smart aleck who may or may not be out there. Yeah, I have a saying that allergic transfusion reactions are more than checked boxes, because in the blood bank we get all these reports of transfusion reactions, and they'll say itching, hives, and they come in, sometimes multiple every day,
Mm-hmm.
and you don't see what's on the other side of these checked boxes. And these are even the ones that are quote mild. Just because they're mild doesn't mean that they're not painful, frightening, extremely uncomfortable. Now, a lot of them are. I mean, some of them are
Mm-hmm.
just a couple of hives and they go away quickly. But even
Sure.
ones that are just listed as itching and hives can be incredibly incredibly disruptive. And
Mm.
I've collected some quotations over the years, because in my research I've talked to hundreds of people who've had allergic reactions, and I've had one guy who told me that he'd rather go through chemo again than have the reaction that he had, which was
Whoa.
just listed as itching and hives, but it was really a full body urticarial burning
Mm.
uh, problem. And
Mhm.
I've seen one patient run around the room screaming because she was in so much agony. And
Wow.
again, that was just hives.
Uh-huh.
But so we don't get the whole story, and
Yeah.
they really are they really are problematic.
It sounds like it's much easier. I mean, let's be honest. Most of us that work in transfusion medicine, you're an exception to that, but most of us that work in transfusion medicine don't have a lot of a clinical background. Most people are pathologists in our field. I mean, that's
Hmm.
just reality. And while I personally did some time as a clinician, most pathologists don't do that. And so I totally hear what you're saying. It's when all you've seen them is from the laboratory side, it's really easy to just think, big deal.
Yeah.
Itching, hive, so what? Yeah, those are scary. Those are scary quotes. You'd rather go through chemo than have another reaction like that. Holy cow.
Yeah,
Wow.
I had another patient who told me she was wondering. She had terminal leukemia, a young woman, and
Uh-huh.
she knew she was going to die. And and she had recurrent allergic reactions, none of which were life
Mhm.
threatening, but they were really bothersome. And she wondered, with the reaction, if that's how she was going to die. Like, am I going to
Oh.
die right now with my, with all these hives and my face
Mhm.
swelling up, and that's awful.
Yep, that is awful for sure. Well, so I wanted to make sure we talked about that first, Will, just so that we could establish to maybe there aren't smart Alex out there. I could be wrong about that, but
It's
in
a
fact, I'm pretty sure I am. It is a hypothetical. It's true. It's something, folks, that we have to take seriously. It's easy to underestimate it. So with that, let's start with our number one topic for today, which is the definition of allergic transfusion reactions. So how do you define them? And well, and is there a standard definition for them as well?
Well, there's a dry definition. There's not really a standard definition, but a
Hmm.
dry definition would be a spectrum of hypersensitivity reactions to transfused blood.
Okay.
But essentially, what allergic manifestations are usually so obvious that you can identify it as, oh, that guy's having an allergic reaction. And
Hmm.
because most of them happen during transfusion, you can kind of put the two together, saying, oh,
Hmm.
he's itching, he has hives, he
Hmm.
has angioedema or swelling, and he's
Hmm.
getting blood, and you say, oh, that's got to be an allergic transfusion reaction.
Okay, and talk to me a little bit about that timing. Is that what you're describing? Is the timing typical, that it's early or during the transfusion?
Yeah, so most of the reactions, almost 90% of them, occur during the transfusion, or within 15 minutes after finishing.
Got it.
So,
Got it. Okay. And so you alluded a little bit to, you can look and you can see some of the manifestations, but can you take us through some of those manifestations? You can go as long as you want. Well, it's a podcast. We got as much time as we want, dude. Rock and
yeah.
roll.
So, the best way to categorize allergic manifestations is by organ system. So
Okay.
if you look at mucocutaneous, you mean skin and mucous membranes, you can have itching, hives, angioedema or swelling,
Mm-hmm.
and that swelling can manifest in a lot of different ways. It can, eyes swelling, lips swelling are two of the more common ones, but it can be tongue. It can be the upper airway, and people can feel like they have a lump in their throat. That's
Mm-hmm.
commonly described. And then there's respiratory manifestations, which primarily are wheezing, uh, like asthma.
Mm-hmm.
And if you can have lower airway obstruction and have stridor. Cardiovascular manifestations are the most ominous is shock,
Mm-hmm.
anaphylactic shock.
Right.
So a drop in blood pressure that's life threatening, but often it doesn't have to be like they don't have to go unconscious on you. Like it can
Mm-hmm.
be a relative drop in blood pressure, um, and some other things that with that drop in blood pressure, of course, the patient's not going to tell you I'm having a drop in blood pressure, but
Right.
they might feel lightheaded, they'll pass out,
Mm-hmm.
they can have incontinence as they lose consciousness. And then something that isn't really talked about in the literature at all is gastrointestinal manifestations. And I have absolutely seen this with allergic transfusion reactions. And it's similar to what happens to people with food allergies. So
Mm-hmm.
when they ingest an allergen, and they will get abdominal pain, cramping, is the main manifestation, and then but that can also overlap with vomiting,
Mm.
uh, and I think people dismiss it because most reactions, as we'll talk about, happen with platelets, and most of those
Mm-hmm.
people are cancer patients, and nausea,
Sure.
vomiting, and belly pain is common in that
Right.
population. But there are absolutely people who have no or perfectly fine from a gastrointestinal perspective, and then when they get their itching and hives, they're doubled over in pain, and then the pain goes away with everything else.
Wow.
So
So that's even with just the what we would technically call mild allergic transfusion reactions, you can have those GI symptoms.
there is a distinction between once you get to two or more organ systems involved.
Mm-hmm.
There are different classification schemes, but I call that a severe reaction.
Okay.
The muco, and it's hard to. There are a couple different ways, pardon me, to slice the definition, but
Mm-hmm.
one way to do it is to say, look, if you have a skin or mucocutaneous manifestation, which occurs in over 90% of all allergic transfusion reactions, you're going to have itching, hives, or angioedema. But if you start spilling over into another organ system, that is a technical definition of anaphylaxis. And so
I see.
if you have itching hives and then you have a gastrointestinal manifestation, that would be two organ systems.
Mhm.
And then we're starting to get in severe.
Okay. Okay. Well, and so, Will, I think that that brings us to something that we should probably address right now, simply because I think that there's still a lot of confusion about some of the terminology that people use around allergic transfusion reactions, especially when it gets to the beyond the mild ones. I mean, mild ones, obviously, historically, people have called those urticarial transfusion reactions, and when you get to the what we would call severe now, I think generally speaking, people have used various terms. You've had anaphylactic, as you mentioned. You've had an anaphylactoid, which I'm not sure anybody knows what that means. But how do you sort all this out? And for someone who's looking at literature and maybe looking at older books and seeing those terms, how do you sort that out with the way we categorize things today?
So the term anaphylactoid and and these other terms are out there, but
Mm-hmm.
I think we should just call them allergic transfusion reactions, and we should call them mild or anaphylactic. And
Mm-hmm.
then within anaphylaxis, you can have really mild anaphylaxis or you can have severe anaphylaxis.
I see.
So
Okay.
I'll just start off on my soapbox and say that's what I
Okay.
think. That's what I think we should do. Now,
Okay.
what happens is uh, people have said, well, it's a severe urticarial reaction or it's an anaphylactoid reaction, and I think we're all describing the same sorts of things. The term
Mm-hmm.
anaphylactoid came about. Um, well, I didn't fully research the origins of the use of the term in the
Mm-hmm.
literature, but people have used it to describe. Purists have used that word, reserve that word for when we don't know like an anaphylactic reaction,
Mm-hmm.
but we don't
Mm-hmm.
know what's causing it. For example, if you have if you have anaphylaxis to a bee sting and you get stung by a bee, you have anaphylaxis. That's
Mm-hmm.
anaphylaxis. But if you get a blood transfusion, we don't know what you're reacting to. We don't know if it's IgE mediated. So it's anaphylactoid. It looks like anaphylaxis, but we're not sure exactly what's causing it.
Uh,
So that's one way people have used it. So in these days, people have preferred the terms immunologic and non-immunologic, and
mm-hmm.
I think that it is actually in the literature by allergists proposed that we just eliminate the term anaphylactoid.
That's good. Well, just so you know, the first time I heard it was probably before your time in transfusion medicine. But the first time I heard that phrase, that term "anaphylactoid" used, was in response to there was a time when patients who were taking angiotensin converting enzyme inhibitors got red cells transfused through bedside leukocyte reduction filters, and they
Yeah,
had some pretty nasty reactions, and those got tagged as anaphylactoid. That's the first time I heard it, but
yeah.
obviously it's been used in a bunch of different ways. I'm sorry to interrupt.
Yeah, no, that's fine because we didn't really at that time. You didn't really know what was causing it, and it
Exactly.
looked like anaphylaxis, but
Yep. Yeah.
yeah. So it's kind of a garbage pail
Right.
term.
Exactly. Exactly. So, well, going back to what we were discussing in terms of the definition, there is something, and obviously we've mentioned that this is significant to patients in terms of how they're feeling when these things occur. But do we have data on how important these are in terms of, well, let's just bottom line it. Are these things killing people?
Yes, they do. They severe anaphylactic reactions
Mm-hmm.
are reported to the FDA when they cause fatalities, and there are usually a couple reported to the FDA every year. And so, on a percentage basis, it's about 5% of fatalities reported to the FDA. I think severe reactions, well, personally, I can say severe, like life threatening anaphylactic reactions. I see a few every year, usually to
Mm-hmm.
platelets or plasma. Um, and where people are like codes are called, and you really have to resuscitate somebody to keep them alive.
Okay, well, so forgive me. I interrupted you just a few minutes ago with my little anaphylactoid story. You were going down a pathway where you were talking about some differences between mild anaphylactic and severe anaphylactic. Why don't you bring us around back to that, if you don't mind?
Sure. So if we define anaphylaxis as an allergic reaction that involves two or more organ systems, which I was
Mm-hmm.
describing before, that's kind of you can meet anaphylaxis on a technical level by having a little bit of wheezing and a few hives. And
Mm-hmm.
clinically, you wouldn't say that that is severe, but on a technical level, you'd say, well, it meets the two organ system criteria,
Mm-hmm.
so we're going to call it anaphylaxis. And in that two organ system uh, requirement really comes from definitions in the world of allergy. So I've
Mm-hmm.
adopted that to be consistent. And so there is such a thing, at least the way I view it, as mild anaphylaxis, where somebody might have some wheezing that and some hives that goes. So you have a lung and you have a skin manifestation,
Mm-hmm.
and it might go away quickly with some Benadryl, and that's it. And you don't even need albuterol or any respiratory treatment or oxygen or there might not even be any hypoxia. So that would
Mm-hmm.
be mild. And then severe, there's not a specific term for it, but I mean, it's criteria for it. But you could imagine if somebody needs medical intervention beyond just antihistamines,
Sure.
your basic treatment, which we'll talk about later.
Mm-hmm.
If you need some sort of quick intervention to prevent the two organ system problem from getting life-threatening, I'd call that severe.
Gotcha. Okay. Okay. So I have to point out, just because I had a few episodes ago, I had Mark Fung on the podcast, and Mark was talking through the standardized NHSN criteria. What you're describing in terms of mild anaphylactic and severe anaphylactic, obviously that's not in there. I don't. I don't know if that's
Yeah.
of any significance at all, but would you like to talk about that for a sec?
Sure, sure. So it's true that that is not in explicitly in the hemovigilance module, but if you
Mm-hmm.
look at the definition of severe,
Right.
the severe essentially encompasses anaphylaxis.
Got it.
Um, so it's kind of in there, but it's not explicit.
Okay, fair enough. We just don't want to diss Mark because we like
Oh,
Mark. Mark's a good
never,
guy.
never, absolutely.
All right. So with that discussion on the definitions, why don't we move on to our second point, which is essentially who gets these things, how they present, and what are the risk factors. Essentially, the epidemiology of allergic transfusion reactions. So take us down that pathway.
Sure. So the allergic transfusion reactions are most common in people who get platelet
Mm-hmm.
transfusion. It's in prospective studies, the incidence is about anywhere 2 to 4% of platelet transfusions will have some allergic manifestation.
Mm-hmm.
That is followed closely by plasma transfusion. It may be 1%, although the quality of that evidence is lower than it is for platelets, but roughly 1% of plasma transfusions will have an allergic manifestation. And again, the quality is a little bit lower for red cells as well as compared to platelet transfusion, but I generally say it's about tenfold, an order of magnitude lower uh, incidence with red cells than it is with platelets. So we're talking
Okay.
about 0.2%, somewhere around there.
Mm-hmm. So that information in years past, I think, has led people pretty clearly to say, and I know we'll get to pathophysiology, but this is obviously a plasma-related phenomenon.
Yeah, and there's other evidence that supports that, but it's we it yeah, it's actually what I've been doing research on recently, and I've actually found that it turns out that platelet proteins, at least when you study this in the lab, that platelet proteins are a stronger activator of allergic responses than plasma proteins. So it may
Interesting.
actually be something that's floating around that's released from platelets that ends up in plasma. And when you remove plasma, it looks like you attribute it to removing the plasma, but it's really
Mm,
stuff from platelets. That's just a hypothesis right now, but
I
it's
see. But it's whatever. It's more complicated potentially than just saying, oh, it's just a simple type 1 hypersensitivity reaction to plasma proteins, as we've said for years. And I know I'm skipping ahead to number 3. I'm sorry, Will, but I can't help myself. I apologize for that.
Yep.
So let's go back to the epidemiology for a second. I know
Oh
you've
yeah.
got a lot to say about pathophysiology, and I want to let you do that. But we've already talked about the fact that the symptoms tend to occur early in the transfusion. What about the duration of the symptoms? How long do they usually last?
So most commonly they resolve in within an hour,
Okay.
um, and probably most of them are resolved within 15 minutes. The mild
Hmm.
ones.
Okay.
I've seen reactions go up to 6 hours or more.
Mm.
Particularly once you get into the mild or severe anaphylactic ones, they can kind of reverberate for a long
Uh-huh.
time.
Okay. Okay. And well, so we've talked about the product that's most associated, the products most associated with it. What about? Well, I'm gonna steal your thunder just a little bit by
Yeah.
saying that you published an article, I believe in 2014 in the Journal of Allergy and Clinical Immunology that I thought was really, really interesting. It opened my eyes in a big way, and I'm wondering if you would mind sharing just some of the stuff that you found in that article about potentially some of the other risk factors that might be around.
Sure. So it turns out the number one risk factor for transfusion reactions, and this study was restricted to platelets,
Hmm.
transfusion recipients, but having a diagnosis of hay fever or seasonal allergies was the one and only really risk factor for allergic transfusion reactions. We looked at
Wow.
people who were allergic in other ways, looking at food allergy, asthma,
Hmm.
eczema, medication allergies, things like that, and
Uh-huh.
nothing else was associated. But repeatedly, it's about a 2.5-fold increased risk of reactions if you had hay fever.
Wow. That's impressive. That's again that goes to what we're going to get to in pathophysiology. I keep teasing pathophysiology, but I mean it's so cool because what you're saying just goes against the basic way that we've thought about these things. And obviously you've been one of the main people that has shown that these reactions are not just as simple as what we used to think.
Hmm.
That by itself, if it was totally a response to something in the plasma, I wouldn't have expected for you to find that.
Yeah. It Yeah, I should say though, it doesn't really predict
Mm,
the occurrence of an allergic transfusion reaction because you can't. You About half of all people, no matter what country you're in, about half, or at least in the developed world, about half of all people have hay fever to some
mhm.
extent or another. So you can't take a patient and say, "Oh, this guy has hay fever; he's going to get a reaction."
Got it.
Uh,
That makes
it,
sense.
yeah,
So, Will, in that same study, you put together a table that I have in my notes. Actually have it right in front of me, and I'll just briefly mention it because I think it's important for people to understand, even though we talked about the differences between mild and severe, how much more frequent the mild symptoms are than the severe symptoms. And, I mean, for example, what you show in that table is that 86% of the people, yes, again, limited to platelet transfusion, allergic transfusion reactions, as you just mentioned, but 86% of the people that were having ATRs had pruritus, urticaria in that ballpark. And the severe ones, the respiratory ones, much, much, much less. 10% with dyspnea, 3.5% with wheezing, and shock just 0.7%. So it's uh, as we look at who's getting these things and how they present, I think it's important to keep in mind that the mild stuff way outweighs the severe stuff, right?
absolutely. And even within those who had wheezing and dyspnea, nearly all of those were mild. And so when I'd talk to these patients, they'd say, "Yeah, I feel a little short of breath," and
Yeah.
you'd be like, "Well, yeah," and you'd listen to them. They had some wheezing, like a little
Hmm.
bit, but you didn't have to escalate treatment for it, and they went
Right.
away. So the ratio is even really higher than what's reported there
Got it.
in terms
Got
of
it.
clinically meaningful levels.
Hmm. Hmm. Okay, well, Will, I honest to God, I can't wait anymore. We got to do pathophysiology because it's
Yeah.
it's really I think again, and I at risk of beating a dead horse, I've said already in this podcast, the work that you and I know it's not just you alone, you and that your team that works with you have done on these reactions has really changed the way we look at these things. In my view, certainly has for me. So here we go. Pathophysiology of ATRs. The floor is wide open for you. Take us whatever direction you want us to go.
Sure. Well, I think it's interesting to review the clinical or circumstantial evidence that helps us think about what's causing this, because the central dogma in transfusion is there's a donor and there's a product and there's a recipient who gets it. So anytime there's a problem, you say, where is the problem in that chain?
Right. Right.
And so the evidence, for a long time has been, that if you wash products, of course not plasma, but if you wash platelets and red cells, that you can reduce the incidence of these reactions. And that was kind of the origin of the idea that that something is bad in the plasma. So one of the studies that we did was called this paired platelet allergic transfusion reaction study, where we took platelet products that were at the time of apheresis collection were so big that you got 2 or 3 components out of one donor. And we looked at situations where those multiple components from the exact same donation got transfused into 2 different people. And we could ask, if it's something in the plasma, then both people, there should be a high concordance of allergic reactions in both recipients. And what we found was actually there was no concordance. That if there was an allergic transfusion reaction in one person, that 99% of the time there was not an allergic reaction in the other one. So it really shifted, said there's something about the patient or the recipient. And that led us led to the study that we talked about before in terms of risk factors. And it turns out that hay fever has something to do with it. So now, of course, you have to have the product cause the reaction. So there is definitely something in the product that's causing it. And the first reports starting in the late 60s were about IgA deficiency and having anti-IgA antibodies causing the reaction. And it all fit, because if you remove the plasma, IgA is in plasma. If you remove plasma, you can get rid of these reactions. And I think it's a really cool insight, and it absolutely exists as an entity. And there was an early report of a high prevalence of platelet recipients having anti-IgA antibodies by hemagglutination methods. And the thing is, though, since then, it really hasn't been generalizable as a mechanism. And I've actually never seen, in 10 years in transfusion, I've never seen a bona fide case of an anaphylactic reaction to IgA because of IgA deficiency and anti-IgA antibodies. And I think one of the reasons that's clung onto as a primary mechanism of allergic transfusion reactions is because we have no information about anything else. So it kind of that observation has expanded to fill the entire mechanism of all allergic transfusion reactions. But we also but that paradigm of being deficient in a protein and making an antibody to it, it does occur in other situations. So in East Asia, where there's it's still uncommon, but a relatively high, I think it's about a 1% range prevalence of ahaptoglobulinemia. So people don't have haptoglobin. They get sensitized through transfusion or pregnancy. They can make antibodies to haptoglobin and have anaphylactic reactions to that. And then there are also some case reports about people having antibodies to C4 or determinants on the Chido-Rogers blood group. So there is, but most of the literature is about really cool case reports. And there are a lot of other mechanisms. There are other weird mechanisms, like the passive transfusion of IgE.
Mm-hmm.
So if the donor is allergic to peanuts, and then you transfuse the plasma, and the plasma gets passively transfused, and then the recipient eats peanuts, they have
Mm-hmm.
anaphylaxis.
Right.
Of course, people are not usually eating peanuts or getting bee stings or whatever while they're getting the transfusion. But
It's true.
it's a cool mechanism, but it doesn't really explain most of them. And actually, the same has happened with antibiotic antibodies.
Mm-hmm.
Um, but one of the things in our study, we looked at about 105 donor and recipient pairs, and we asked, what is the donor allergic to? What is the recipient allergic to? And what did the donor eat and take in terms of medicines? And what did the recipient eat and take in terms of medicines? And we
Mm-hmm.
tried to match up. Were there any cases where, the donor had a allergy to egg, and the patient had
Mm-hmm.
eaten egg in the
Right. Right.
which is going to be a lot more common than peanut, and
Mm-hmm.
we found nothing. So
Right.
we can't generalize that as a mechanism. Um,
Hmm.
so those are so kind of, because we can't generalize those, we say all those mechanisms rely on plasma
Mm-hmm.
being transfused, and because of the C4, the haptoglobin, the IgA, and that's in the plasma that people can have antibodies to. People have generalized that into, well, it's people have antibodies to things in plasma, and it very well may be, but
Mm-hmm.
and it could be that there are a million different kinds of them, and we only know about 3 or 4 of them, but
Mm-hmm.
we just don't know a lot.
So let's get real practical for people that are actually for two different groups of people. First, for people that are preparing to take a standardized examination of some sort. That people, we still get asked about these things. So if you're taking an exam and someone describes a perfect anaphylactic severe anaphylactic transfusion reaction, and one of the choices is IgA deficiency, I'm guessing you're probably going to recommend that we still choose that. Am I right or am I
That
wrong?
that is right. And even if I'm writing the question, I'll still. If it's a well-written question, it shouldn't be confused with, very similar type answers. If that's
Gotcha.
a selection, it should be pretty obvious.
Got it. Got it. And I think you make a really important point about the haptoglobin and C4, and the haptoglobin in particular is something I've been pointing out in my teaching in recent years, especially in those, as you said, of East Asian descent, to at least think about it. But the other, I guess my second point, the practical one for people taking exams, was the first one. But my second point is that for those of us working in transfusion services and reference labs, the reality is, unfortunately, we usually, when you get one of those severe allergic reactions, you usually don't know, right? You can't find a specific mechanism in most cases.
In nearly all of them, actually.
Yeah.
And another practical point is to look at the transfusion history of the patient,
Mm-hmm.
because nearly all severe anaphylactic transfusion reactions are idiosyncratic, and you can't predict them. So if you
Mm-hmm.
have somebody who has had loads of transfusion, and then boom, they
Mm-hmm.
get an anaphylactic reaction, the chances of them doing well with subsequent transfusion is actually really high, without
Yep.
making, of course, you're obligated to wash at that point. But even in cases of plasma, like with a
Mm-hmm.
TTP patient who has anaphylaxis, we've repeatedly re-exposed people to single donor plasma, and it works. It works fine. They are going to
Mm-hmm.
be predisposed, most likely, to other allergic reactions, but it's not like, if you think about it, if somebody really has an antibody to a protein that is causing anaphylaxis, even if it's just an isotype or a polymorphism of some protein in a donor, they should be reacting a lot more frequently, and it's usually just a
Right.
one-off.
That's the take-home message, and I can't tell you how often I have that discussion with hospitals. My current role is in a blood center, and I have had so many discussions with hospitals who are asking for IgA products from IgA deficient donors,
Mm-hmm.
and for who are freaking out about one anaphylactic reaction, which is obviously scary, but making grand assumptions on what they have to do, querying rare donor registries for IgA deficiency, et cetera, when they don't have evidence that that's the case. It's knee jerk, I guess, is what I'm trying to say. And
Yeah.
there's way too much of that.
Yeah, where you do get stuck is when somebody has an anaphylactic reaction in their first couple of transfusions.
Mm-hmm.
And you don't know, and they could have an antibody to something that's not yet
Right.
prescribed, and those are hard. Although
Yep.
we do have data from 3 different studies that show that the incidence of allergic transfusion reactions actually decreases with subsequent exposure. Um,
Fascinating.
so the more you transfuse, actually, you tend people worry about this crescendo of symptoms. Like if I
Mm-hmm.
keep giving it to them, they're going to get worse and worse. But actually, the rate goes down over time.
That's a really important practical point. I hope everybody caught that. It's exactly opposite of what you might think.
Yeah,
Exactly opposite.
I mean, the reactions sometimes it doesn't mean that they won't have anaphylaxis again. It
Right.
doesn't. But if you just look at the incident, you don't have to. And it's not attributable to increased pre-medication.
Okay. Yeah, we'll get to that in just a
Yeah.
second, and on the when we hit the 4th point. But before we leave pathophysiology, because it's been so much fun, and I'm serious about that. I'm a nerd, so tell me, is there anything else that you want to hit before we move on to management?
I think that is. I think that for now, I hope to have a great update in 5 years. But for now, I think that'll suffice.
Fair enough. Well, okay. So let's move on to management and potentially even prevention of these allergic transfusion reactions. And I'm guessing that we'll probably need to tackle these in 2 phases. The first phase being the mild ones, and the second phase being the nasty ones. So why don't we talk about the mild ones first? How do we manage or potentially even prevent the mild allergic transfusion reactions?
So for the mild ones, the evidence from a couple of randomized controlled trials that do have their flaws, but and also several large cohort studies show that pre-medication, which is usually the first thing people think about with prevention
Mm-hmm.
and treatment of reactions, those data cumulatively show that there is really no preventative role for pre-medication.
Okay.
So we're talking about primarily diphenhydramine, or also brand name Benadryl.
Right.
And there are a few points to make about it. One is that pre-medication is like a cultural psychological issue. Some people are so convinced that it's necessary. It's ingrained in practice.
Right.
It's just curious that in spite of the data and in spite of the long list of side effects that diphenhydramine has, and even in spite that in the last 20, 30 years, we have much better non-sedating antihistamines that you could use.
Mm-hmm.
Why people insist like Benadryl is so important. And you see that it's embedded into order sets, and
Oh yeah.
it's, you just can't, it's hard to extract it without putting in a lot of energy to change
Mm-hmm.
practice. So, and if you think about other hypersensitivity reactions, we don't try to always try to prevent them. So the analogy I use is people with asthma and treating it with albuterol. You don't tell people keep taking your albuterol in case you start wheezing. Albuterol is a medication for treatment, and so you say, okay, if you feel like you're starting to wheeze, then take your albuterol. And I think the same is true for allergic transfusion reactions. So
Mm-hmm.
Benadryl is I think the first choice drug when you start having symptoms. It's a drug that's available everywhere that blood is transfused, and if somebody's and since over 90% of these reactions are mild, what's the harm in just waiting for somebody to have a reaction and then give it to them, rather than pre-medicating the 98 out of 100 people who won't have any reaction.
Right.
And
Right.
I think there's also this part of the psychology is that people when they give a pre-medication, because with a platelet transfusion, let's say, there's a 98% chance that patient's not going to have a reaction. If they
Hmm.
do something, they interpret the lack of a reaction, they attribute it to their
Mm.
pre-medication. When
Of course.
I joke about proposing a randomized study of me standing on my head versus Benadryl to prevent reactions. And say, well, geez, Will stood on his head, and 98 out of
Man,
100 times, nothing happened. That's
you got
great.
to propose that, man. Somebody's going to bite on that. So I think my perspective on that, Will, is that I think a lot of clinicians and blood bankers, for that matter, who've been asked about it in the past, kind of have the impression that diphenhydramine is just a harmless thing, right? And that's maybe a misperception, wouldn't you say?
I'd say absolutely. The first thing I always ask is have you ever taken Benadryl? And you say, how is that for you? And
Yeah.
not all the time, but most of the time, people say, oh yeah, it makes you feel dissociated, like
Yeah.
dizzy. You get tired, like you're non-functional for 6 hours.
Hmm.
And I said, so why are you doing? So why would you do that to somebody else? And there's also in people with medical issues. It can
Hmm.
promote urinary retention. It can promote falls
Hmm.
in people who are already at risk for falls.
Right.
There's so many bad things about it.
Hmm.
Just a couple of weeks ago when I was on service, there was somebody who had incontinence from his pre-medication because he couldn't completely void
Oh,
his bladder, and
man.
he was a grown man wetting his bed because every time they pre-medicated him in the hospital, and he finally started refusing it from the nurses, and I empowered that. I said, good
Good
for
for
you.
him. Yeah,
I said,
good
there's no
choice.
reason for that.
Okay, so in terms of the mild reactions, you know what? Before I move on, let me ask you this one thing. The one thing that people push back on, with the diphenhydramine or with pre-medication in general, whether we're talking about just that or also adding acetaminophen, for example, to try and prevent febrile reactions, people will push back a little bit on people that have a history of those reactions. In other words, if you're transfusion naive or reaction naive, yeah, I think I can usually convince people there's no sense in doing it. But for those who have had a history, how do you respond when clinicians try and do that?
So I think it depends on the history of the individual patient. In
Hmm.
the study that I did for platelet transfusion, there were around 140 patients getting platelet transfusions chronically.
Hmm.
And when you look at the incidence of allergic reactions in those patients, it really starts falling off after an incidence of 5%. So we talked about an incidence of 2 to 4% per
Hmm.
transfusion. But when you take one patient and you say they've already had a reaction, most of them fall in the 3 to 5% range. And really once you get past so in other words, 1 in 20 transfusions, and the the most extreme is really was about 1 in 2 transfusions on a recurrent basis. So
Hmm.
even when you have the worst reactor ever, they're at most, at least in my study, they reacted half the time, and
Hmm.
usually like a really uh, and again, but mostly that kind of peaked at around 5%. So 1 in 20 transfusions. So most of the time, even with a frequent reactor, most of the time they're not going to have a recurrent reaction. But
Got
if
it.
it's a nuisance, I
Hmm.
can fully appreciate sometimes that when they have recurrent reactions, they're clustered, and
Hmm.
they'll be and it you have to weigh the risk and potential benefit, and if it's really causing a problem, like for an outpatient, they have to come back because they're having a reaction, and they go to the ER or whatever it is. Sure, give
Right.
them you can pre-medicate them, and you also have to
Hmm.
look at how bad the Benadryl is affecting them. So it's
Right.
okay, but I definitely, even with somebody who's had a reaction, as a matter of routine, I do not recommend it. I think you got to look at what the reaction pattern is and the severity and the consequences.
Okay. All right. That makes sense. Well, why don't we, since we're running just a little bit short on time, why don't we move on to talk about treatment of the severe allergic reactions, the anaphylactic severe allergic reactions? What do you do with them?
Sure. Just one final point, though, is
Sure.
I
Go ahead. Well,
alluded
I'm
to it
sorry.
earlier that you know, pick up the Zyrtec and Claritin and Allegra
Ah,
instead of the Benadryl for these chronic.
got
If
it.
somebody's having recurrent reactions, just give them one of those.
Hmm.
Um, they're going to tolerate it a lot better, and they last for 24 hours. So it's a lot easier than Benadryl.
Perfect. Thank you for pointing that out. That's a really great point. Then, and everyone, I hope that's really clear to you. Your Benadryl is not your only option. In fact, there are much better options, as Will just mentioned. Thank you for pointing that
Sure.
out, Will.
So going on to the severe reactions, I think there are the one thing that is often overlooked as a first step is to avoid transfusion. You know, we all know with the blood utilization movement that a lot of transfusions are not necessary. So I think the first step is to really scrutinize how important it is for this patient who had an anaphylactic reaction to get another unit. Like, do they really need it?
Right.
The the second thing is if you're talking about red cells or platelets, is to plasma reduce them. And you can use, if it's really a severe life threatening reaction, I think you have to go straight to washed.
Hmm.
If it was something that was kind of in between in terms of severity, platelet additive solution platelets have been shown to reduce the incidence. So those are an option.
Hmm.
If
Just not available everywhere yet,
not available
but
everywhere.
yep.
If you deem plasma is essential, even though we have so few data, we really don't have. I don't know if we have any data that plasma is really need. Well, massive transfusion for sure, but there's so much data, so
Hmm.
much of the plasma we give is not necessarily indicated. But if you say it's absolutely essential, um, one product, the solvent detergent plasma products, which again aren't
Hmm.
available. They're available, but you just have to get them
Right.
in your inventory.
Got it.
Um, Solvent detergent plasma is an option, and then you really have to look at if this person with anaphylaxis was indeed one of the rare IgA deficient patients, and then you can look at IgA deficient plasma
Hmm.
if you
Hmm.
confirm that. But as we talked about before, usually with anaphylaxis, they're idiosyncratic, and the history bears that out, and you can
Yep.
keep transfusing them. Those people tend to have recurrent allergic reactions, but usually don't get severe anaphylaxis again.
So that, and I wanted to discuss that real quickly, Will, because I've given that advice to doctors in terms of people that have had plasma reactions where after a pretty thorough investigation, there's the reaction remains somewhat of a mystery. And I've told them what you just said, that the likelihood is that they're not going to experience another anaphylactic reaction, but they always ask, well, okay, what precautions should I take when I'm transfusing this patient? Should I do all these transfusions in the ICU? How should I handle it? So how do you handle those queries?
Yeah, I think it always depends on what the history is. I think
Hmm.
yeah, usually the because they've had a severe anaphylactic reaction, they're often already in intensive care, and because they
Sure.
needed that first transfusion, they need another one soon
Right.
after. So it's usually monitored. But I do think that it's prudent. I mean, there's not evidence really to directly support this, but you should be around a code cart, people who know how to
Hmm.
resuscitate somebody. That's true with any transfusion, though, so that's not necessarily special. I think it is. You can. I think it is a good idea to pre-medicate these people
Hmm.
because though it might only take you a few minutes to grab the drugs, if the person's going to have a bad reaction, you're probably better off if they're on board already. And
Hmm.
when I talk about pre-medication, I'm talking about the antihistamines, Benadryl, but also the histamine receptor 2 antagonists like the Pepsids and Zantac and those sorts
Hmm.
of things, because it turns out that histamine acts on H2 receptors as well. So you want to give an
Right.
H1 blocker, like which is the Benadryl or the Zyrtec, but you also
Hmm.
want to give the H2 blockers. People talk about steroids as a pre-medication, and in the world of allergy, it's not thought. There's not direct evidence for it, but it's thought that the steroids help suppress what are called late phase reactions, which kind of the recrudescence of symptoms 2 or more hours after a reaction. And most of the immediate reactions you see in anaphylaxis are not affected by a steroid premedication. And of course, you always want to have epinephrine around because that is the number one treatment of choice for anaphylaxis.
I'm actually pretty impressed that we got this far in the podcast, and that's the first time we've used the word epinephrine. Nice job.
Yeah.
But yeah, you're right. I mean, that's what I had just jotted a note to myself that if we didn't mention it, that's the key point, that for the immediate urgent treatment for someone with an anaphylactic transfusion reaction is epinephrine. Do you have any comment on how to give epi? Because people go back and forth on whether it should be IM, whether it could be IV in those cases. What do you typically recommend?
So epinephrine, and this is, you just want to use the code cart dose. 0.5 milligrams is the standard dose, and for an adult. And you want to get the consensus recommendation is to give it intramuscularly. The problem with giving it subcutaneously is that because epinephrine vasoconstricts, it's going to take longer for it to get into the bloodstream. The problem with giving it IV is epinephrine is an incredibly powerful chronotrope and inotrope, and that means making the heart beat faster and stronger. And so if you give a huge dose of it IV where there's no kind of spreading out of the dose as it gets absorbed through the muscle, if you give that bolus, you can cause a heart arrhythmia. But of course, if that's the only way you have, I mean, sure, that's fine.
Understand. All right. Is there anything else that pops into your head that you want to leave us with?
Yeah, one thing I forgot to mention before in looking at the risk of allergic or anaphylactic reactions is that there is no association with the ABO matching of the units, and there's also no association with the infusion rate. Again, this is just for platelet transfusion, but it actually, whether you transfuse fast or slow, in our study, it didn't affect the incidence of anaphylaxis. And sometimes people say, well, if they had a reaction, let's slow it down. It's never a bad idea to slow it down.
I've said that.
It's always good to slow it down, but as far best we can tell, it's not going to change their risk. And I think that has to do with the fact that most of these reactions happen during infusion, and you aren't even getting the whole product before you're reacting. And so even if you slow it down, like you don't need a whole lot to cause the bad reactions. And anaphylaxis, when I talked about mild allergic reactions happening during or within 15 minutes after transfusion, the bad anaphylaxis ones usually happen within the first 15 minutes. You don't need a whole lot of product.
Yeah. Okay, that makes sense. Man, well, we've buzzed through a whole bunch of information in a pretty quick period of time. I want to give you the last crack. Is there anything else before we close this that you feel like we've missed, or that you want to emphasize or reemphasize to our audience?
Well, I could keep talking for another couple hours, but I would the first thing I would say is just one. I always like to tell people about my going back to the beginning, my career choice to go into transfusion medicine coming from hematology. If anybody happens to be listening to this from maybe what's considered a non-traditional pathway to transfusion medicine, that it is a completely viable option, and it's actually a fantastic way to go. And there are many of us, we're growing. We aren't quite zombie apocalypse levels, but there are many of us who'd be happy to talk to anybody interested. And the second thing is just to, like anything in medicine, just think critically about the management. And this seems to be a problem with all the problems we have in transfusion medicine. Is like the rest of the clinical world has plenty of other things to worry about, and they don't think about, transfusion is number 17 on their list of concerns. And we always want people to think more about it. And so allergic transfusion reactions are no different. You can't just write them off and be like, whatever. I think we have a small duty to be practice evidence-based medicine around it and think critically and keep doing research, try to figure these things out.
It's great advice. It's great advice. Well, Will, I can't thank you enough for spending time with us and my audience here on the Blood Bank Guy Essentials podcast. I think that you've shined a very practical and important light on this stuff. And as I mentioned, I wasn't kidding when I said at the beginning that the work that you and the group at Hopkins has done on these reactions has completely changed my way of approaching them and thinking about them. It's been just really great to catch up with you and to hear what you have to say about this. So thank you so much for being on the podcast.
All right. Thank you.
Hey everyone, Joe here with just a couple of closing thoughts. There was a lot in that discussion that I found enlightening, and I hope that you did too. Among the things that really struck me, there were so many, but I think the patient descriptions that Dr. Savage gave us of how people feel when they're having these allergic transfusion reactions, even the ones that we would consider as mild, were really startling and eye-opening to me. Another thing that really stood out for me is the whole concept that diphenhydramine or Benadryl is not necessarily benign, and it's not necessarily something that we should just be tossing around indiscriminately. And I thought Dr. Savage made some great points about that. And the very last thing that he said just really jumped out at me. He mentioned that in patients with a severe allergic or severe anaphylactic transfusion reactions, that the speed of the transfusion has no bearing. And I'll be honest with you, I have advised clinicians in the past, if they think the patient is at risk, if they've had a previous one, for example, transfuse slowly and watch them. Turns out that may not have necessarily been the best advice. But I found it really very interesting. We focused primarily on the lower end of the spectrum for obvious reasons. They happen more often. But quite honestly, Will swims in the deep end of the pool with all this stuff, you guys. If you ever get a chance to hear him talk in more detail about allergic transfusion reactions, please avail yourself of the opportunities, because there's a whole lot more that he could have talked about, but again, it got into a little bit more depth than we needed to get here. And further, if you want more information on severe allergic or anaphylactic transfusion reactions, I would highly recommend that you check out an AABB audio conference, which was done in late November 2016 by 4 great doctors, one of whom has been on the Blood Bank Guy Essentials podcast, Dr. Ann Eder, as well as Drs. Jerry Sandler, Jeff Winters, and Mindy Goldman. They go into great detail on severe allergic transfusion reactions, how to manage them, and the whole controversy about whether there really is an IgA-mediated anaphylactic type of transfusion reaction. So that brings us to the end of the Blood Bank Guy Essentials podcast for 2016. I am so honored that you've made this podcast such a success. In the 8 months that I have done it, through your kindness and faithfulness in listening to the podcast, we have had over 25,000 downloads in that 8-month time frame. Really incredible, and I thank you so very much for that. There's lots of new and exciting changes that I have planned for both the Blood Bank Guy Essentials podcast and the website in 2017. So please, if you have not done so, head on over to bbguy.org, and right there on the front page, there's a place for you to sign up for the email list. I'll never spam you, but it'll just keep you in touch and let you know things that are coming up. Lots of really great stuff, and I hope you'll do that. So that is the podcast for 2016. For the very last time this year, I would like to tell you that as you go through your day, my wish for you is that you'll smile and have fun, and above all, never ever stop learning. Thanks very much. We'll catch you next year on the Blood Bank Guy Essentials podcast.